So today I will be talking to you on hyperphosphatemia in chronic kidney disease and the role of a new molecule that is sucroferric oxyhydroxide. So hyperphosphatemia is an important problem in patients with chronic kidney disease. And as Sir had already told, there have been a lot of molecules from calcium-based phosphate binders to non-calcium-based phosphate binders, and now newer molecules which have come into the picture. So briefly about the hyperphosphatemia and its management. So I'll be talking under the following headings. First about CKD, MBD, and phosphate homeostasis, and about the hyperphosphatemia in chronic kidney disease, the role of sucroferric oxyhydroxide in the management of hyperphosphatemia, what are the clinical evidence and latest updates on this new molecule, and place of sucroferric oxyhydroxide therapy, and summarizing. So introduction to CKD MPD. So chronic kidney disease and mental and bone disorder is a systemic disorder which is associated with increased risk of morbidity and mortality in patients on dialysis and CKD patients. Now, chronic kidney disease, mental bone disorders involves various biochemical abnormalities in calcium, phosphorus, PTH, associated with bone disorders and vascular calcification. And all of this can culminate in cardiovascular events. There is increased propensity to fractures and other serious complications, which can result in increased mortality. So management of hyperphosphatemia is important because it is associated with various complications. Now, CKD MBD, there is a complex interaction between various systems. Most importantly, the intestine, gut, the bone, and the kidney. And there is a complex interplay of three major hormones. One is vitamin D, parathormone, and FGF23. So vitamin D acts on the intestine to increase the calcium and phosphorus absorption. And in the bone, it increases calcium deposition, and kidney, it causes calcium reabsorption. Ultimately, we result in maintenance of serum calcium and maintaining the bones. While parathormone, it acts via vitamin D on the intestine to increase the calcium and phosphorus absorption. And on the bones, it causes calcium resorption, and the kidney, it causes increased calcium reabsorption while increasing phosphate excretion. So this helps to maintain the serum calcium at the expense of the bone. The FGF23 tends to rise early in the course of chronic kidney disease. Because of hyperphosphatemia, there is release of FGF23 from the bone osteocytes, and this again acts on the intestines indirectly through vitamin D, and it causes a decrease in calcium and phosphate reabsorption. And it is primarily a phosphaturic hormone. It acts on the kidney and causes increased phosphate excretion. And this is mainly responsible for the maintenance of serum phosphorus. So this is the pattern of markers as kidney function declines. You can see that the FGF23 tends to increase, and the PTH levels tends to be high, and there is hyperphosphatemia which stimulates the increase of FGF23, and there is a loss of vitamin D, decreased production of vitamin D, resulting in decrease in calcium. So the phosphate homeostasis in humans is maintained by the complex interplay of these three hormones. And the main source of phosphorus is a dietary intake of phosphorus, usually around 1,000 to 2,000 milligram per day. And the phosphorus gets absorbed in the intestine, especially in jejunum and ileum. And the various hormones which I already discussed, parathormone is a phosphaturic hormone which directly acts on the kidney, and it stimulates the osteocytes to release the calcium and phosphorus to the extracellular space, and PTH can activate the vitamin D. In contrast, vitamin D can inhibit the PTH hormone secretion, and it increases the absorption of both calcium and phosphorus, and as well as FGF23 is primarily a phosphaturic hormone, and it can suppress the vitamin D. So again, the PTH vitamin D axis is mainly involved in the regulation of serum calcium, and it has got secondary effects on systemic phosphate homeostasis, as already described. While FGF23 is a phosphatoric hormone, which is mainly important in the regulation of serum phosphorus levels. So what happens in CKD is there is a dysregulation of the CKD mineral bone balance, and this may result in hyperphosphatemia. The normal serum phosphorus is usually between 3 milligram to 4.5 milligram per deciliter, and hyperphosphatemia usually occurs when the kidney function is impaired to the extent that all the compensatory mechanisms will fail to eliminate the excess phosphate. Initially, when there is a decline in GFR, there is hyperphosphatemia, and this tends to be compensated by an increase in FGF23 levels. And this will cause increased phosphate excretion as well as inhibition of calcitriol production, and in which ineffective maintain the phosphate homeostasis. Now, the low calcitriol, because of the elevated FGF23, causes a reduction of calcium absorption, and this hypocalcemia can stimulate the parathormone secretion, and this helps to increase the phosphate excretion, but can result in secondary hyperparathyroidism. And these compensatory mechanisms may help to normalize the elevated phosphorus as well as the calcium concentrations in the CKD patients to some extent. But as the CKD progresses, the renal phosphate excretion gets affected, and excess of dietary phosphate accumulation results in persistent hyperphosphatemia. So what happens is there's dysregulation of the phosphate may lead to the cardiovascular diseases. So phosphate retention can result in secondary hyperparathyroidism, and this can also result in bone and cardiovascular disease in CKD patients. In CKD patient, this calcium as well as phosphorus can get deposited in the medial layer of the blood vessels, mainly in the arteries or the cardiac valves. This can result in vascular calcification and in the widened pulse pressure, left ventricular hypertrophy, increased cardiovascular events, and mortality. So that is the importance of hyperphosphatemia in CKD. So let us go into the topic proper, that is the management of hyperphosphatemia in CKD patients. So as I already said, the main sources from the diet. So one way of tackling hyperphosphatemia is the major way is to restrict the dietary phosphate intake. And second is by enhancing the elimination of phosphorus and removing the phosphate with adequate dialysis. And even with diet restriction and dialysis, may not be able to remove the phosphate or bring the phosphate load to the normal. So you may need phosphate binders, which will limit the phosphate being absorbed in the food. So the novel paradigm for hyperphosphatemia includes the 3 Ds, that is the diet, the dialysis, and drugs. So dietary intervention is very important in patients with CKD, and the 2017 KDIGO guidelines have listed have educated the monitoring of calcium, phosphorus, and PTH values. And the calcium, the goal is to avoid hypercalcemia, phosphorus to be brought back to the normal range, and PTH to be kept between 2 to 9 times upper limit of normal. So this can be achieved with the diet, dialysis, and drugs. So that is, so you have to assess the serial assessment of phosphate, calcium, and PTH levels should be considered together. And decision about phosphate lowering treatment should be based on progressively or persistently elevated phosphate levels. And those patients with CKD stage 3A to 5D who are receiving phosphate lowering treatment, they also educate a restricted dose of calcium-based phosphate binders. And in adult patients with CKD stage 3 to 5D to avoid hypercalcemia. So regarding the diet restrictions, this is very important. It is known that animal diet contains a lot of protein and phosphorus, and the proteins, those food products which contains protein also contain excess phosphorus. So in patients on dialysis, restricting the protein intake may be sometimes difficult, and as a result, patients, though the recommended is to restrict the phosphorus to less than 800 to 900 milligram per day, sometimes that may not be possible, and it can result in malnutrition. So again, you need to note that among the source of the food or the source of phosphorus varies between the plant, animal, as inorganic additives, and the bioavailability also varies. So the for plant proteins, the bioavailability is only 30 to 50%. That is the intestinal absorption. Like grains, legumes, and nuts are rich in phosphorus. Again, animal meat, cheese, fish. The bioavailability is quite high, and this is most for inorganic additives. So many times these products are the hidden sources of phosphorus, and that should be taken into account. And soda, prepared food, canned foods can the bioavailability is almost 100%. So restriction knowledge about this is very important and should be educated to the patient. And these are some of the hidden source of phosphorus, as shown. Food additives tend to contain, and many of these the food labels may be poorly labeled. Again, something of interest is phosphorus can be seen in many medications. So more than 10% of drug formulations do contain phosphorus, and this can also contribute to daily phosphorus intake. And in patients who are taking many of these medications simultaneously, for example, in antidepressants like paroxetine, amlodipine, which is a calcium blocker, also contains phosphorus. Antihypertensives like lisinopril, sitagliptins. These are some of the few drugs which may contain phosphorus. So that's about the dietary aspect. And regarding the elimination, that is achieved through dialysis in patients on maintenance of dialysis. Again, regarding the about the modality, it also the removal varies according to the modality used. And for a conventional hemodialysis, usually each session remove around 600 to 200, 1,200 milligrams of phosphorus. And as the duration of dialysis increase also, there is more phosphorus is removed. And in nocturnal dialysis, there is more effective phosphate removal. And CAPD around 600 to 2,000 milligrams is removed for so on an average, if you do dialysis for a week, around 4,000, around 600 and 4,200 milligrams of phosphorus may be removed. Just to highlight the challenges in the treatment of hyperphosphatemia, in patients with advanced CKD, there is loss of kidney function and impaired renal excretion of phosphorus. And when you do the dialysis, it tends to remove phosphorus, but again, dialysis is not sufficient to remove or reach the target range of phosphorus in majority of patients. And again, the other source of the phosphorus is through the diet, and it is important to restrict the intake of phosphorus as in and as phosphate additives and other to remember other hidden source of phosphorus. Again, increased protein requirements necessitate dietary phosphorus, so it cannot be restricted significantly. Phosphate binders are used may help to reduce phosphate absorption. Again, the problem is with the high pill burden and the adverse GI effects associated with many of these phosphate binders. And once usually the secondary hyperparathyroidism happens, there is a release of phosphorus in the bones, and these phosphate binders may not be that effective also. So you may need vitamin D to suppress the PTH or calcium mimetics to suppress the PTH to address the secondary hyperparathyroidism. So what is the ideal phosphate binder? An ideal phosphate binder is a binder which binds phosphorus in the digestive tract. And this is minimally absorbed, and it should not cause any vascular or cardiac complications. It should have a high binding capacity. It should be non-toxic and well tolerated, and should translate to good clinical outcomes with reduced mortality risk, and should be easy to administer, and the pill burden should be minimized as much as possible. That is a criteria for an ideal phosphate binder. Now, let us look into the various phosphate binders which are available. So the various calcium phosphate binders, the phosphate binders are the calcium-based phosphate binders, which include the calcium carbonate, calcium acetate, and calcium citrate. Then you have the aluminum-based phosphate binders, which is aluminum hydroxide, which is no longer used. And then cevilamine hydrochloride and cevilamine carbonate, and lanthanum. Then the iron-based phosphate binders, which includes ferric citrate and the novel sucroferric oxyhydroxide. Now let us look into the limitations of the currently available phosphate binders. So the earliest one is the calcium-based, which includes calcium acetate and calcium carbonate. Now, calcium-based phosphate binders are quite effective, and they are very inexpensive also. But the problem with calcium-based phosphate binders are there is increased risk of hypercalcemia, increased risk of vascular calcification, and possibly all-cause mortality, calcified laxus. Again, the increased pill burden is required for calcium acetate. And then you have the recently the which is widely used, the non-calcium based phosphate binders. Aluminum hydroxide. Aluminum hydroxide is relatively inexpensive, and it has got very high ionic binding affinity, and low pill burden is required. But it is not commonly used because of the complications like adenemic bone disease, dementia, and osteomalacia and microcytic anemia. So aluminum toxicity is a problem. So it is not commonly used except for short-term rescue therapy, but otherwise aluminum hydroxide is not used. Lanthanum carbonate is a potent phosphate binder, and again it is quite potent, and the pill burden is less, and it is effective over a wide pH range. But the problem is a metal-based phosphate binder, and there is risk of accumulation and toxicity for lanthanum. Again, cevilamine has been the one which has been commonly used nowadays. Cevilamine carbonate, cevilamine hydrochloride. It has good efficacy, but the pill burden is more, and it is quite expensive. And the other problem is that the GI side effects are quite high with cevilamine carbonate, and there is a potential for metabolic acidosis with cevilamine carbonate, and there is interference with the absorption of fat-soluble vitamins. And metabolic acidosis was more with the ceramyl hydrochloride, which is not seen with ceramyl carbonate. And next is the iron-based phosphate binder, which is ferric citrate. The ferric citrate, the advantage was that it improved anemia in patients with CKD. Along with the phosphate binder, it improved anemia, and lesser dosage of erythropoietin and iron was noted in patients who are on ferric citrate. But continuing for a long time, ferric citrate can result in iron overload and toxicity. Ferritin levels as high as transfusion as high as 80% maybe, and it can lead to iron deposition on the liver and other organs, and there's iron toxicity associated with ferric citrate. So these are the problems with the calcium, the phosphate binders. So the final is sucroferric oxyhydroxide, which is associated with less complications, and the pill burden is quite potent, and the pill burden is also less. So just this slide is to highlight the importance of the additional treatments for the control of hyperphosphatemia. So daily dietary phosphate intake is usually 1,000 milligram per day, which can come to around 7 grams a week. And of this, around 60% get absorbed. And so the phosphorus required in normal is around 4.2 grams per week. And if you do dialysis, around 600 to 1,000 milligrams removed, which may come to around 2.4 grams. So there's phosphorus balance of 1,800 milligram per day. So on a daily basis, around 257 milligram has to be removed. And in it, so these, if you so the various calcium phosphate binders have different phosphate binding capacities. For calcium carbonate, 1 gram binds 40. So you may require around 6 to 8 tablets. Again, calcium acetate similarly, cevilamine 1 gram binds 36. So 6 to 8 tablets usually required. Lanthanum is quite potent, and 8 gram binds around 93, and aluminum hydroxide around 60 to 75 milligram. And of which the most potent among the newer ones is the sucroferric oxyhydroxide. 1 gram binds around 100 milligram. So around 2 to 3 tablets can take care of the excess phosphorus. So just already discussed. So something about so in patients on these medications can still have failure of phosphate control. So in such situations, you have to remember it could be due to pseudo hyperphosphatemia. One is can be due to incorrect sampling of phosphorus, or it may be with a high dietary. So attention dietary intake is very important, and patient should be counseled regarding the same. And some of the patients may be on high doses of vitamin D metabolites, especially when the hyperphosphatemia is not corrected, and adding vitamin D metabolites can result in hyperphosphatemia. And there is phosphate containing drugs, anemia, infusion. This has to be looked into. The dialysis adequacy, the duration, frequency has to be. And in advanced secondary hyperparathyroidism, again, the phosphate binders may not be that effective. And the metabolic acidosis can cause shift of phosphate from the intracellular to extracellular space. So addressing that is important. And some of the patients, though they are prescribed phosphate binders, because of the side effects, they may be non-compliant to those things. And there is a incorrect intake or the timing of the phosphate binder. That also has to be specially mentioned to the patient, the timing as well as the dosing of these phosphate binders. So these are some of the things which should be looked into when the patient, despite treatment, there is failure of phosphate control. So now let us go into the new molecule, that is sucroferric oxyhydroxide, and its role in the management of hyperphosphatemia, which is a novel non-calcium ion-based phosphate binder. Now, sucroferric oxyhydroxide is an oral ion-based non-calcium phosphate binder, and this is formulated as a chewable tablets. It is broken down and then in this chewable, and 500 milligram iron equivalent to 2,500 milligram of sucroferric oxyhydroxide. Now, this contains a polynuclear iron oxyhydroxide core, and this is stabilized by starch and carbohydrate shell containing starch and sucrose. Now, this carbohydrate shell preserves the phosphate absorption capacity. Coming to the mechanism of action, it binds the dietary phosphate in the gastrointestinal tract by ligand exchange between the hydroxyl and the phosphate ions. And this bound phosphate is then excreted in the feces and prevented from being absorbed into the blood. The phosphate binding capacity of sucroferric oxyhydroxide, it's observed at a wide range of pH ranging from 1.2 to 7.5, and the maximum peak binding capacity observed at a pH of 2.5. And it shows minimal ion release over a physiological relevant pH in the GI tract. And the sucrose as well as starch components can be digested into glucose and fructose and maltose and glucose respectively. So it is a potent phosphate binder. In each gram of sucroferric oxyhydroxide can bind approximately to 60 milligram phosphorus in the gut, while when compared to a gram of sevelamer, which binds to only 21 milligram phosphorus. So it is quite potent, and which might translate into lower pill burden with sucroferric oxyhydroxide. And as a result, there's a better chance of patient adhering to the treatment regimen. So let us look into the clinical evidence and latest updates on this the new molecule and the trials. So this sucroferric oxyhydroxide has been used as a first-line monotherapy, as well as it has been used as a switch-over therapy and as a combination therapy. So first, let us look into some of the trials looking into its role as a first-line monotherapy. Now, this was a real-world effectiveness of sucroferric hydroxide as a first-line phosphate binder. And when it was initiated during the first year of dialysis. So this study looked into around 596 patients, and the patients were on hemodialysis patients were on sucroferric oxyhydroxide monotherapy as a part of routine clinical wear within the first year of hemodialysis. They looked into changes from the baseline in serum phosphorus, achievement of a serum phosphorus less than 5.5 or less than 4.5 milligram per deciliter, and other parameters were also looked quarterly as well as at the end of a year. So what they found was that sucroferric oxyhydroxide treatment was associated with significant decrease in quarterly serum phosphorus, and the daily pill burden was approximately only 4 pills. And when they looked at the percentage of patients who achieved a serum phosphorus of less than 5.5 milligram per deciliter was 55 to 60%, and those who achieved a serum phosphorus less than 4.5 was around 24%. So concluding, among patients with hemodialysis, when sucroferric oxyhydroxide was initiated as a first-line phosphate binder, this led to significant reductions in serum phosphorus while maintaining a relatively low pill burden. So next study was looked into the role of sucroferric oxyhydroxide as a switch therapy. And the aim of they looked into the effectiveness of sucroferric hydroxide versus other phosphate binders in hemodialysis. So aim was to compare the real world effectiveness of sucroferric oxyhydroxide versus other phosphate binders in hemodialysis patients over the 2 years. So retrospective cohort study where they looked into sucroferric oxyhydroxide and when they were switched to other phosphate binders. So at the end of 2 years, they found that in sucroferric oxyhydroxide therapy, the patients who achieved a serum phosphorus less than 5.5 milligram per deciliter was the 21% is the baseline, and on follow-up, 47% achieved a serum phosphorus less than 5.5 target. While in those who were switched to the other phosphate binders, only 34% achieved serum phosphorus less than 5.5 milligram per deciliter. Again, the pill burden was significantly less in the patients on sucroferric hydroxide, starting from 8.5 and follow-up it was only 5.1 pills, and in the phosphate binder group it was 11.6, and on follow-up it was 10.9 pills. So compared with the discontinued sucroferric oxyhydroxide, maintenance sucroferric oxyhydroxide had 35.6 fewer hospitalization per 100 patient years. So the pill burden as well as better phosphate control was achieved in patients who were on sucroferric oxyhydroxide during the 2-year follow-up. So the patients who were maintained on sucroferric oxyhydroxide were more likely to achieve target serum phosphorus levels, and they were prescribed 50% fewer pills per day and fewer hospital admissions than patients who were switched to treatment with other binders. Now, there are a few studies which looked into sucroferric oxyhydroxide as a combination therapy and as a monotherapy in treatment-naive and pre-treated patients. So this study was done in a multi-center study in France, Italy, Spain, and Portugal. So this is a real-world study which looked into the role of sucroferric oxyhydroxide in European hemodialysis patient, which is a 1-year retrospective database analysis. And they had patients who were phosphate binder naive patients who were treated with sucroferric oxyhydroxide monotherapy, and then there were phosphate binder pre-treated patients who were switched to sucroferric oxide monotherapy. The phosphate binder pre-treated patients who received sucroferric oxyhydroxide in addition to other phosphate binders. So the serum phosphate and pill burden were combined between the baseline and 4 consecutively quarterly periods of sucroferric oxyhydroxide therapy in the overall subgroup, the cohort, as well as the 3 subgroups. So when they look in the overall cohort, the serum phosphorus decreased significantly from the baseline, and the mean pill burden was also decreased significantly from 6.3 to 5 to 5.3 in the first quarter. And in sucroferric oxyhydroxide, daily pill burden was low across all the 3 subgroups. So in patients who are on sucroferric oxyhydroxide and patients who are on combined therapy, the pill burden was quite less, and they achieved their target serum phosphorus. So retrospective database analysis of more than 1,000 dialysis patients from these 5 European countries showed that with the treatment of sucroferric oxyhydroxide, when prescribed as a monotherapy to patients who were phosphate binder naive or in addition to existing phosphate binder therapy, there was significant improvement in serum phosphorus with a lesser pill burden. So sucroferric hydroxide, it is marketed as Dynulta, and this product name is Dynulta. It's a 500 milligram chewable tablet, and each chewable tablet contains 500 milligram iron, which is equivalent to 2,500 milligram sucroferric oxyhydroxide, and the starting dose of sucroferric oxyhydroxide is 500 milligram, 3 tablets daily with meals, and the serum phosphorus levels must be monitored, and dose is titrated up or down in increments of 500 milligram. That's 1 tablet per day every 2 to 4 weeks until the acceptable serum phosphorus that is less than 5.5 milligram per deciliter is achieved with regular monitoring thereafter. So you may start with around 2 to 3 tablets a day. So 3 tablets usually required in the Western diet. Indian diet mostly consumes plant proteins, may not require that much. So if you start with 500 milligram twice daily and then monitor the phosphorus levels, and adjust the dose accordingly. The maximum dose recommended is 6 tablets per day, and the important thing to note is that tab must be chewed and not swallowed, so that the better phosphate binding action is there, and it should be broken and then chewed. And no additional fluid above the amount usually taken by the patient is required. And if one or more doses are missed, the medication can be resumed with the next meal. So this can be used in a specific population. The safety and efficacy of sucroferric oxyhydroxide have not been established in patients, pediatric patients less than 14 years. And in geriatric patients, there is no overall difference in safety or effectiveness when compared to younger subjects. Some of the adverse drug reactions are diarrhea, nausea, and loose stools. So patients may complain of nausea and diarrhea, and no significant overdosage reports are there. And place in therapy, it can be used as a first line monotherapy, as well as in patients who are non-responding to previous phosphate binder therapy or resistant hyperphosphatemia despite all other phosphate binders, or can be used as a combination therapy. So just ending by saying that sucroferric oxyhydroxide has got several benefits when compared to other phosphate binders. In terms of treatment efficacy, it is quite potent. The pill burden is less, and it is most well tolerated by the patients. And starting dose around 500 milligram 2 to 3 times daily. And it's an easy to chew tablet with convenient dosing. And there is minimal iron absorption, which no evidence of iron accumulation over the 52 weeks.